Hello, my name is Monica Ridgway, and welcome to the Kentucky Finding Cases Project Finding New HIV and HCV Cases Equals Early Diagnosis presentation. I'm so excited that you have decided to join this presentation and learn a little bit more about what we're doing in Kentucky to end the HIV epidemic. All right, just to let you know, there is no financial relationships to disclose. The educational need and practice gap it's disclosed right here, basically, that healthcare agencies will have to work together at local, regional, and state, national levels in the state of Kentucky, finding ways that we continue to basically prevent and work together to assure that there are not as many ongoing transmissions of HIV as well as hepatitis C in Kentucky. Our practice gap is basically that HIV and hep C infections continue to occur throughout Kentucky. And the reason why is because a lot of people are not getting tested. But our goal is to assure that we work together and we collaborate amongst medical and non-medical agencies and organizations, which would include, of course, community-based organizations, nonprofits, aid service organizations, as well as local health departments. So the learning objectives is by the end of this session, you'll be able to see and indicate how timely HIV testing and early diagnosis supports the approach to eliminate HIV adopted by the National HIV/AIDS Strategy, which is NHAS, the 90-90-90-50 plan adopted by the District of Columbia, the new Ending the HIV Epidemic, a plan for America proposed by the U.S. Department of Health and Human Services, HHS, that we will identify strategies to reduce transmission of HIV and hepatitis C, including community HIV and HCV outreach and engagement, pre-exposure prophylaxis, which is PrEP education and awareness, harm reduction best practices and principles, discuss HIV infection rates disparities amongst IDU and MSM IDU and drug user communities. This includes injection drug users that are white male IDUs, white female IDUs, Black female IDUs, Hispanic male IDUs, and Hispanic female IDUs, as well as trans women and trans men. The fourth learning objective is to summarize strategies for prevention, testing, and care among injection drug users, IDU, and men who have sex with men, IDU users, and of course the drug user communities. All right, the expected outcome is that students will have a better understanding of the prevention and treatment strategies being implemented in Kentucky to prevent the transmission of HIV and hepatitis C. So before I start this presentation, I always try to give people acronyms. There's several acronyms that we use when we work for aid service organizations or when we work to fight against HIV as well as hepatitis C, and we work amongst drug user communities, working in harm reduction as well as risk reduction. So it's a list here, but some of the ones that you may see that do not look familiar, of course, is the KYFC, which is Kentucky Finding Cases Project. So we didn't want to make it look like it was KFC as in the chicken KFC. So we added a lowercase y, which of course, if you know anything about your states, all of the letters are supposed to be capitalized. So, but we did something a little different and we added the lowercase y for KYFC. The KDPH, which is Kentucky Department for Public Health. KDAP, which is of course Kentucky AIDS Drug Assistance Program, CURP, which is a new program throughout the state of Kentucky, which is Kentucky Income Reinvestment Program, CHOWs, which are community health outreach workers who are some of the workers who work on this program, PWs, which are peer workers. And something that looks fairly new right here, as you can see, is BIPOC. We've been using it in the last couple of months, even more heavier. And it basically is Black, Indigenous, and people of color, as well as, let's see, anything else that's new? Nope, all the other ones are pretty much familiar. So you can take a look at that, screenshot it, take a picture. It'll be available though, but it's just a lot of acronyms. There's more than these acronyms, but these are just to kind of get you going. So if you hear me say something with some letters and it doesn't sound familiar, I'm pretty sure it's on this, this key sheet. All right, so the mission of CURP is to eliminate new HIV infections in the state of Kentucky by providing comprehensive education and screening services to those at high risk for HIV infection, linking identified HIV positive persons into high quality state of the art medical care, and improving access to supportive services to ensure HIV positive persons enjoy health and well-being, educating current healthcare providers and students in training to address the substance use disorders and the mental health issues that hinder the provision of effective HIV, Hep B, and Hep C medical care. The vision of the CURB is to enhance the healthy, safety, and well-being of all people in the Commonwealth of Kentucky by addressing high-risk behaviors, providing comprehensive education, and expanding state-of-the-art care for persons living with HIV. So the CURB initiatives that we have in this program is the Harm Reduction Initiative, which is HRI, Health Education Collaborative, Prevention Care and Treatment Program, Innovative Pilot Program. The Innovative Pilot Program, which is one of the programs that the Kentucky Finding Cases Project is under. The innovative pilot programs within this program is investment funds and pilot programs for innovative projects throughout the Commonwealth. It addresses access to care and supportive services for people living with HIV and those at highest risk. These programs will be identified as priorities of the Cabinet for Health and Family Services Department for Public Health. Most must comply with the federal Ryan White HIV legislative program. Initiatives must engage low-income individuals living with HIV and or are at risk for contracting, transmitting HIV and AIDS. So these are some of my favorite quotes. One of them is by our past president, which is Barack Obama. Innovation is the creation of something that improves the way we live our lives. Another one is innovation is something fresh, new, original, or improved that creates value. That's from Jeff Dance. And another, one of my favorite innovation or innovative quotes is innovation is any idea that adds value, and that's from the Baxter Healthcare from Australia. So to be innovative is to introduce new ideas, original and creative thinking, to feature new methods, advanced and original. So one thing about being innovative, you have to be new. It's not saying that you're letting go of the past and it's all over with. But what you're doing is, adding something new, a new idea to whatever you already have established. For instance, I always use the Know Your Status campaign was something that was really heavy in the 90s and in the early 2000s. Because when I was a student at Alabama State, they was pushing that know your status, know your status, know your status. So they're still pushing know your status, but they've changed some of the lingo now. So instead of them always pushing know your status, they have programs and campaigns such as Know Your Health. And it's just knowing your health in general, because even if you are HIV positive, you still want to make sure that you're taking care of your health. You want to make sure that you are assuring that you are in care if you are virally suppressed, as well as even if you're, because not everyone that's virally suppressed is undetectable, but you want to assure that you're doing whatever it takes to know your health. Or I'm trying to think of another status. Oh, also, get yourself tested. That's another campaign versus Know Your Status, because you can get tested for many things when it comes to knowing your health. All right, so the Kentucky Finding Cases Project is an innovative pilot program. So that's why I want to give you guys a little bit about innovation and what it meant, because this program is an innovative pilot. It was developed by the Kentucky Department for Public Health, the HIV prevention section. The central focus occurs in the highest HCV incidence areas, which have remained at low HIV rates, perhaps only due to not being adequately tested. It measures and evaluates the achievability of conducting rapid HIV testing through outreach in community settings, such as using incentivized evidence-based practices and multi-sectoral partnerships by creating and establishing regions throughout Kentucky. So the progress to date, we've hired a program manager, we've hired 6 community health outreach work team leads, we've hired 7 community health outreach workers, and we're hiring the remaining community health outreach workers and peer workers in the designated area. So while the people that have already been hired, they have been shadowing other community health outreach workers throughout our AIDS service organizations throughout Kentucky, as well as our local health departments, to kind of get their hands wet, get their feet out there, put their boots on the ground. Even during COVID-19, they are still learning what they will have to do to continue to end the HIV epidemic through the community outreach program. So I have a map right here of those 6 regional areas, and I'll talk a little bit more about the regions and why they have letters and why we chose this and why we chose that and why we chose the certain counties that have been picked. All right, so here's our organizational chart right here. We have the Kentucky Finding Cases Program Manager, which is myself, and then we have Region A, B, C, D, E, and F, and we have a child lead in each of the regions. We have hired, as you can see, certain childs. We have a couple more that we actually have interviewed, and we will be moving forward. Hopefully, we'll have this all together. Things have been postponed due to COVID-19, but we are really excited to know that we are assured that we will be moving forward. All right, so let's talk a little bit about this innovative pilot program. The goal is to increase HIV testing by going into rural areas considered out of reach. Kentucky has over 54 vulnerable counties, and a lot of those counties are in rural areas. So that's why we go into the rural areas that are considered out of reach. We will increase access to care to assure improvement in virus suppression rates amongst people living with HIV. We will address health inequities to end HIV transmission. We will increase PrEP, awareness, and education to providers and people who are most vulnerable for HIV. We are pushing PrEP. And we are also pushing that because, for one, it is implemented and included in our EHE, which is ending the HIV epidemic. But we're also pushing it because a lot of times when we are providing awareness and education, the people know more about PrEP than the providers. And our goal is to assure that those medical providers are getting the education for they can suggest and encourage their clients and their patients that come in to see them for just regular checkups to get on PrEP. But in order for them to do that, they have to be well educated. People still have a lot of stigma associated with HIV and the barriers and what to use and what other preventative ways that they should use when it comes to HIV. So our goal is to make sure that we are encouraging and educating our medical providers as well as the people in the community. Also, the KYFC project will support the uptake of HIV testing to identify early infection and facilitate linkage to care in the Eastern, Southeastern, and Western regions and improve outcomes. KYFC team will expand HIV testing to people who are using drugs by using a culture responsive approach, and will reach many PWID who are not participating in syringe exchange programs or syringe service programs. So we have the most syringe service programs in the state of the United States. But with that being said, we want to assure that the people that we're reaching are not even going into the SSPs. There are people who have not even yet reached or went to the SSP, so they don't have access to care or they don't know where to go. So our goal is to meet the people where they're at, but don't leave them there. So our goal is to embrace older strategies that target only certain populations or venues with historically high positivity rates while transitioning to interventions to improve testing and linkage implemented in diverse venues such as community-based orgs, correctional facilities and clinical settings, including emergency departments, primary and urgent care settings. So our goal is to also make sure that we're including things that have already been used, that have already been proven to be effective, even EBIs, effective based interventions. But we also want to make sure, evidence-based interventions, but we also want to make sure that we don't just use those, but we also use newer ones that have been supported by the CDC, as well as other federal organizations that support a lot of the HIV campaigns. Such as Let's Stop HIV Together, Let's Stop HIV Stigma, Start Talking, Stop HIV. So we're trying to make sure that we're still implementing the One Test, Two Lives, and Prevention is Care, as well as TASP. So those are our goals, is to still embrace those old strategies, but transition by using newer ones. So the Kentucky Finding Cases Project, why the regional areas? As you can see, this is that infamous 54 counties that you know that Kentucky has of an increased vulnerability to a rapid dissemination of HIV and hepatitis C infections. This study was implemented in March 2015 after the 2015 Scott County outbreak that had awakened the entire United States because of the outbreak of HIV. Because of this federal analysis in 2015, out of the 3,000 plus counties in the United States, 220 of those counties were vulnerable. And of course, Kentucky held 54, which was 26% of the vulnerable counties. But out of that, Kentucky, West Virginia, and Tennessee holds 56% of the most vulnerable counties. So we wanted to assure that we did whatever it takes for us not to, unfortunately, I hate to use Scott County all the time, but we just want to make sure that we don't have a certain situation like we did in Scott County, Indiana. So we do not want history to repeat itself. So timely HIV testing, early diagnosis. We do know the first steps of HIV treatment is timely diagnosis. And in order for us to meet the goal of 90% of Kentuckians knowing their HIV and hepatitis C status, it means increasing targeted testing. It means encouraging us to go into areas that are high risk areas and going and doing target testing for those who are HIV negative but are considered high risk individuals. Supporting the social network strategy that encourages CHOWs and PWs to engage social networks that continue testing, education, and awareness. And how we'll do that, of course, is we will assure that all of these ways, these things will be implemented through all of the three things right here, which is the NHAWS, the 99-90-50, and the EHE. So just a little bit about the NHAWS. I mean, I know I don't want to go too much into that because we have learned about the NHAWS for years. It's a 5-year plan that was released in 2010 under the President Obama administration. The 4 primary goals include that we would reduce HIV infections, increase access to care for people living with HIV, reduce HIV-related health disparities and health inequities, and achieve a more coordinated national response to the HIV epidemic. The 90-90-90-50 includes that 90% of Kentucky residents with HIV would know their status. 90% of persons are diagnosed with HIV would be in treatment. 90% of persons in treatment will achieve viral load suppression. And of course, at the time, it was 50% decrease in new HIV cases. As we know, things have changed since the new ending the HIV epidemic. The goal is that the EHE will reduce a new HIV infection by 75% by 2025. And 90% by 2030. So we go back to know that the EHE focuses on 4 key strategies that together can end the HIV epidemic, and that's to diagnose, treat, prevent, and respond. So a lot of this is very similar to the NHAWS. A couple of things have changed over the years, not that much, but it's an older strategy with the NHAWS, and we're just embracing a new strategy. So one thing that has changed is that they are pushing, and I'm not going to say necessarily change because PrEP was also included in NHAWS, but it's implementing PrEP and preventing HIV through the SSP programs throughout the nation and just responding quickly to potential HIV outbreaks. So just like the Scott County outbreak, we wanted to assure that we didn't have a situation like that here in Kentucky. So our surveillance team and our prevention team in HIV assured that they quickly responded to what could have easily been an HIV outbreak. So what they did was they jumped on it quickly. They came up with strategies and they came up with HIV outbreak plans, and they did what they had to do to assure that they are monitoring those in Northern Kentucky as well as the entire state of Kentucky. Now, this is just a picture of how important that state of Kentucky is. We're so important, we're a priority state, along with the other priority states that you see on the map. So our goal, and this is just repetitive, is to identify strategies to reduce transmission of HIV and hepatitis C. We use CHAMPS, which is Community HIV Medical Prevention Services Curriculum, Social Network Strategy, Harm Reduction Network Strategy, and the ARTIS, which is the Antiretroviral Treatment and Access to Services. So just a little bit about CHAMPS. We have not actually implemented this yet. We are still waiting to hire our entire staff, but we can go ahead and implement this training. It consists of community health worker workforce development, which trains members of the target population to recruit and train organizations to conduct condom distribution, individual and group level interventions, provide HIV and hepatitis C venue-based testing, linkage to care and patient follow-up services of HIV and hepatitis C screening, and linkage and retention and care for persons living with HIV and hepatitis C while capturing all of the required data. We use the SNS. This is pretty successful. It really works because it's a programmatic, peer-driven recruitment strategy to reach the highest risk persons who may be infected by but unaware of their status. Using these social networks are very, very helpful because every network has a network. So I always include this is basically I have a group of people I hung out with college, but I also had a group of people I hung out at work. So I had different groups of people, and then they had different groups of people, and I also had other groups of people. So it's like it's a lot of people that we go from group to group. So we're networking with different people. And that's the good thing about with working in drug user communities. Every drug user doesn't hang out with the same type of people. We use that as a stereotype, as well as people who are at high risk are not always around the same people. They have different networks. But the good thing is, if you know one network, they can show you their other networks because they gain your trust. And this is a very, very good strategy because it takes advantage of the social networks of people who are members of the community. That's why our goal is to hire peer workers, people who actually know the community that will be serving daily. And of course, we have the harm reduction navigator training. This is probably one of the best trainings that anybody actually could go through, because if you're working in drug user communities and you're working in harm reduction, I really suggest that you go through this training. It's one of the most hands-on trainings that we've experienced and that this team will experience, because you're teaching those who work in outreach and work with drug user communities on how to handle people and how to work with people, non-judgmental zones. And that is something that we make sure that we implement when we're working with the communities that we are serving. It teaches you the language. It uses evidence-based interventions. And anytime someone goes back and forth with you about surrender exchange programs, you don't even really have to go back and forth. You can give them the evidence-based interventions that we use, and harm reduction navigator training is one of those. Also, ARTIS is very important because it is to assure that if someone does test positive, how we link them into care immediately. We don't wait really the 90 days, but the 90 days is the maximum when it comes to ARTIS. So how are we going to assure that we reduce transmission of HIV and hepatitis C? We're going to reinforce all 4 of those strategies. So health disparities in healthcare amongst PWID and PWOOD. What is a health disparity? A health disparity refers to a higher burden of illness, injury, disability, and mortality experienced by one group relative to another. Health disparities refer to differences in health and healthcare between groups that are closely linked with social, economic, and or environmental disadvantage. So some of the disparities amongst PWID and PWOOD occur in many dimensions. As you can see, we have race and ethnicity, social economic status, age, location, sex, gender, disability status, and sexual orientation. A lot of times we have to remember that location matters. We always focus on certain areas, metropolitan areas typically. We always focus on white men who are PWID or PWOOD populations. Sometimes we forget to focus on the social economic status because that matters. And we tend to miss certain numbers because we don't really work to assure that we are hitting all races and ethnicities. So how do we do that? We assure that we include BIPOC when it comes to race and ethnicity. A lot of times we're not able to gather the numbers when it comes to PWID populations, because we're not going into those areas that serve African Americans, or in certain areas that have a high rate or a high number of African Americans. I use the West End of certain cities a lot of times have high numbers of people of color, but we're not in those areas assuring that we are serving those people and serving everybody. Social economic status, how will we address that? We'll include low income groups. How will we address age, including youth populations and older adults? We sometimes forget about that older generation, that older age, or the more seasoned adults. We only focus on youth populations, but older adults do need the prevention strategies as well to assure that they are not sharing syringes as well as sharing bodily fluids. So location also is including living in rural areas and inner city areas. A lot of times we focus on metropolitan areas and inner city, like I stated before, but Kentucky has a lot of areas in Eastern Kentucky that's considered the hollers or the hollers. So we want to make sure with this program that we go into those areas, those out of reach areas who don't typically have access to care or access to transportation. So we're going to them, we're meeting the people where they're at. Gender, including cis women. A lot of times we do not include cis women like we should. And in order for us to end the HIV epidemic, we have to include women. Also, I said gender, including trans women and men. And a lot of times I think we don't understand that trans women and trans men is not associated with their sexual orientation. That is their gender. So we have to make sure that we're being all inclusive and making sure that we're actually getting their feedback, asking them what they need from us, and going and doing what we have to do to meet the trans women and men where they are. Disability status, including individuals with special healthcare needs. So people don't really focus on that, but that really matters. We never know what we're working with and who we're working with, who could possibly have documented disabilities. So we have to make sure that when we're saying we're all inclusive, that we really are all inclusive. Sexual orientation, including LGBTQIA plus communities. And I have T in bold because that is not trans women and trans men are not considered. It's not sexual orientation, it's their gender. So I just want to make sure that I always implement that and include that. So the strategies for prevention, testing and care. We want to assure that we assure that HIV testing linkage to care is important. The same things, it's just reiterating what we will be doing with this program. All right, another innovation quote, learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. That's what William Pollard said. Listen, what happened on Monday or what worked on Monday typically never works for me on Friday. So I don't know about you, but anything that happened for yesterday or anything we did yesterday may have worked, but you never know what'll happen on Wednesday or on Friday or on Saturday. Things typically change. So I said that to say, God dog, my favorite math problem. COVID-19 plus innovation equals creativity. So what are we doing? We are implementing drive-through HIV and hepatitis C testing, drive-through DOPE, which is drug overdose prevention education, and Narcan distribution, drive-through community health fairs and drive-ups, kind of like Sonic. We're driving up to you, walking up to your car, we're getting your blood, we're doing what we got to do. And then having community health fairs outside with social distancing and proper PPE. We have looked at some other organizations throughout the nation. We see that Kansas City is doing great work. So we have GWAP, that good old flyer. They're doing good work. I just want to recognize them for that, as well as Tacoma. They're doing really, really good work. And people are already doing what they have to do because HIV prevention didn't stop. It didn't stop because COVID came. Nothing ever stops because something, happens. I know we're in the height of a global pandemic, but we are already facing a global pandemic called HIV. And we're still here to do what we have to do to assure that we stop the spread of HIV. And we just got to do what we got to do. We got to get out there in the trenches put that PP on like we supposed to, and social distance as much as possible. Take your vitamins, eat a little better. You know, we kind of was stuck in, some of us gained the quarantine 19, i.e. me, but I'm still here to talk about it. So that's a good thing. Things are happening every day, but I'm glad that we're all sticking together, knowing that we're all better together, and we have to do what we have to do to prevent HIV. All right, so I want you guys to meet the KYFC project team. These are our leads. I know they all look the same, right? Well, this is who they look like without the mask. So when they're by themselves or not around other people, this is who they look like. It's my leadership team. Here are the 3 childs that have already started. We got more coming. They are all looking alike with their proper PPE. And when they're by themselves, not around people, no PPE. So, all right, so here's some more references. I want to really thank my project team. We got Charlie Peck, Deborah Verbogen, Susan Gent, Venetia McGregor, Shanae Whitlock, Ricky Bosick, Alexis Bigham, Bernard Anderson, and thank you for attending my presentation. This is my contact information, and of course, hashtag KY harm reduction, KYFC project. All right, so if you have any questions, I'm most definitely here to answer any of your questions. My goodness, I have so much to talk about. I know I only had so many minutes, but I hope you enjoyed this presentation. Our goal in Kentucky is to end the HIV epidemic together. We are lucky to have several partner organizations, including the Kentucky Department for Public Health, the University of Kentucky CURP program, as well as our AIDS service organizations throughout the state of Kentucky, and as well as our local health departments and any other partnering organization that works with us closely. Thank you so much for your time.